ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ದಿಸ್ ಇಸ್ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಅಬಾದ್ ಖಾನ್. ವೆಲ್ಕಮ್ ಟು ಮೈ ಯೂಟ್ಯೂಬ್ ಚಾನಲ್ ಅಗೇನ್. Today I am doing case-based discussion. Let's learn medicine together and in a very simplest possible way. So here is a 9-month-old male child who was brought by mother with complaints of cough, cold since 7 days, watering of eyes for 7 days, fever for 6 days, red colored rash for 2 days. This is a case of fever with rash. The cold was in the form of clear watery running nose. Fever was low grade. Rash first started around ears, which was maculopapular red in color, and progressed to involve trunk extremities, sparing palms and soles. Eye discharge was watery in nature. So here is a rash which was maculopapular, first started around the ears, then progressed to involve other parts of the body except palms and soles. So this has a cephalocaudal spread, and which is a maculopapular. And if you notice here, this child is having a face up, just cried face, just cried. The child is appearing like a just cried, but child did not cry in last 6 hours. This is the clue for this condition. If anyone can make diagnosis from all these clues or just by looking at the face of the child. And here also we have maculopapular rash. So already we have seen one condition to which was having cephalocaudal progression, which is scarlet fever. So here also rash, maculopapular rash we can see. From all this data, so we come to the diagnosis which is known as measles, also known as rubella, and this is endemic all over world. Endemic all over world. And don't get confused between rubella and rubella. Rubella is also known as German measles. Okay. Introduction. It's a highly contagious viral infection which causes fever with rash, which is characterized by cough, coryza, conjunctivitis, fever and rash. Epidemiology. Organism causing measles is measles, which is a negative sense single stranded RNA virus belonging to family Paramyxoviridae, genus Morbillivirus, and route of spread is respiratory route, and which is highly communicable. The age group 6 to 5 year, and lesser the age, more severe is the disease, especially less than 1 year severity increases. Okay, and it affects malnourished children, and in malnourished children the disease is severe. So malnourishment, morbidity, mortality increases. Okay, and secondary attack rate is highly communicable, more than 90%, because virus remains suspended in air even when person leaves the room. If the person has sneezed or coughed in a room, and the virus remains in the respiratory droplet and viable for 2 hours, and if someone comes in contact with this, can affect a susceptible individual. The season is winter and spring. The measles is 4th day rash, and we need to know all other rash which comes on which day. Already we know or previously discussed in scarlet fever. So on day 1 we have varicella, day 2 scarlet fever, day 3 pox, on day 4 we have measles, and day 5 typhus, day 6 dengue, day 7 typhoid. So here is a pathogenesis of measles. The portal of entry is respiratory by respiratory droplet. Once virus takes entry, it attaches to respiratory epithelium, and there is a primary viremia to lymphoreticular system, and there is a secondary viremia through blood to the organs and skin. After secondary viremia, prodromal symptom starts, okay, in the form of cough, coryza, fever, conjunctivitis, and there are later we have a complication, pneumonia, encephalitis, death may occur in a certain individual. And in a prodromal symptom we have a triple C, 3 C's: cough, coryza and conjunctivitis. Okay, and virus can be suspended in air up to 2 hours once case leaves the room. Okay, person may not be face to face contact even if he enters the room which is infected by a person with measles can get a measles infection. So this is the image showing timeline of measles. There is an exposure respiratory droplet and the spread occurs by respiratory droplet. Incubation period is around 7 to 14 days and there is a prodromal phase starts after incubation period and which lasts for 4 days, 1 to 4 days. After that, on the 4th day we have a rash which is morbilliform maculopapular rash which starts in the neck region or the head region then spreads to lower down cephalocaudal down, and the infective period is 4 days prior and 4 days after the onset of the exanthema or rash. And there is a special entity called as Koplik spot which is an ananthema which occurs 1 to 4 days prior to onset of the exanthema which is pathognomic seen in cheek area. After the exanthema phase there is a recovery phase which lasts for 7 to 10 days child feels. Usually symptom starts in the prodromal phase and which are progressive in the intensity. Then once the rash starts the symptom subside. Okay, prodromal phase begins with mild fever followed by onset of conjunctivitis with photophobia, coryza, prominent cough. So here is a question MCQ can be asked on which is the prominent feature of measles, which is cough. Okay, and increasing fever, but on the after onset of the rash symptoms subside. Okay, the measles in older days measles was diagnosed on the background of very bad cough, but nowadays we are seeing modified measles which has milder cough. Here is the image showing complication of the Nelson image showing complications of the measles, and this is a Koplik spot which has a red spot with whitish blue center. Okay, and this is the image maculopapular rash, cephalocaudal spread, and this is the our patient's image. Koplik spot, it is the ananthema pathognomic of measles, appears 1 to 4 days prior to appearance of the exanthema, that is in the prodromal phase. Discrete red lesion with bluish white spot in the center on the inner aspect of the cheek at the level of the premolar. Initially it appears at the level of premolar. They may spread to involve lips, hard palate, gingiva. Conjunctival fold, vaginal mucosa may also show Koplik spots. You need to remember all these sites and MCQ can be asked like this. Koplik spots seen in all the places except, they will give all the options and you have to choose the wrong one. This is the image showing Koplik spots which is red in color and center with bluish white spot. Complication, you can remember by all itis, head to toe, whatever itis you know, you have to name them. The most common one is otitis media, and the most common cause of death is pneumonia. And other complications are sinusitis, keratoconjunctivitis, conjunctivitis, giant cell pneumonia, laryngitis, bronchitis, croup, bronchiolitis, meningitis, meningoencephalitis, SSP, diarrhea, myocarditis, malnutrition, hemorrhagic measles, which is a severe form of measles. Morbidity, mortality are highest in immunocompromised patient. So this is the image showing all the complication. In respiratory we have otitis media, laryngeal croup, bronchitis, pneumonia. Pneumonia can be viral or secondary bacterial. Then bronchiolitis. In central nervous system we have measles, child can develop febrile seizure, acute encephalitis. Then we have in skin secondary bacterial infection, myocarditis, hepatitis, eye keratitis, keratoconjunctivitis, blindness, otitis media, gastrointestinal diarrhea, dehydration. In immune system immunocompromised, it suppresses immunity. The most common cause of death in measles is pneumonia. You need to remember this can be MCQ. Okay, all are true about measles except they can give otitis, they can give myocarditis as a most common cause of death, but it is a wrong answer. You have to choose that. Modified measles. So what is modified measles? So people are less contagious. If the person is having modified measles, he is less contagious than actual measles. Occurs in people having passive antibody such as infant having a maternal antibody or recipient of blood products, as well as vaccinated individual. Note, modified measles is a milder form, may not have all the symptoms, rash may not be typical, and it becomes difficult to diagnose. Usually the measles is diagnosed on the background of bad cough. Okay, but in modified measles may not be having bad cough or running nose or coryza. Okay, you have to have a high index of suspicion to diagnose modified measles. Whose symptom measles last longer? This is MCQ. The options are fever, cough, coryza, conjunctivitis, and the answer is cough. The cough is the most prominent clinical feature of measles as well as the symptom which lasts longer. Pneumonia and measles can be due to virus itself or superimposed bacterial infection, and the virus causes giant cell pneumonia because of necrosis and formation of the giant cell at the respiratory epithelium. Most common bacteria involved are Streptococcus pneumoniae, H. influenza, Staph aureus. This line is taken from the Nelson. Pneumonia is the most common cause of death in measles. Severe pneumonia can end up in either death or it can have a sequelae as bronchiolitis obliterans. TB and measles. Measles suppresses skin response to TST, that is tuberculin skin test or Monto's test. Okay, because it suppresses immunity, so the response to tuberculin skin test is less. And pulmonary TB activation may occur in individuals with measles who are already infected with TB or measles encephalitis. It is mainly seen in adolescent and adult, which is immune mediated, usually seen during exanthema period. So we have a period of, this is prodromal phase, and then there is a rash, this is a exanthema phase, then there is a recovery. During this period we see the measles encephalitis features in the form of seizure, lethargy, irritability, coma, and the mortality is very high, a 15% mortality, which carries a poor prognosis. Okay, and another 20 to 40% patients suffer long-term sequelae, that is post-meningitic sequelae. Note, in immunocompromised patient, direct damage from virus rather than immunological damage. The measles encephalitis in immunocompromised patient is direct damage from the virus, not immune mediated. What is MIB? Anyone? Measles inclusion body encephalitis seen in immunocompromised patient occurs within a year of infection, and it has a poorest prognosis, 100% mortality, universally leading to deaths. These lines are directly taken from Nelson, and this can be a potential MCQ. Retinol and measles. Inverse correlation between serum retinol and measles severity. Low levels of retinol associated with increased measles morbidity and mortality. Measles infection itself lowers serum retinol levels, so subclinical cases can be made symptomatic. So what is the WHO recommendation on vitamin A therapy in treatment of measles? 2 doses are recommended on day 0 and day 1. If symptomatic, third dose should be given after 2 to 4 weeks of last dose. Diagnosis of measles, usually clinical, serological and PCR based tests can be used to support the diagnosis. Treatment of the measles, mainly supportive, maintain hydration, oxygenation, comfort are goal of therapy. Respiratory failure from croup pneumonia may require ventilatory support. Prophylactic antibiotics are not recommended. Okay, you have to remember antiviral therapy. Ribavirin may be tried in pneumonia and ventilated patient, especially in immunocompromised. So we have to give vitamin A supplements, that is 2 doses in asymptomatic and 3 doses in symptomatic. Isolation to prevent the spread for the period of infectivity. Okay. The vaccine in measles. So measles vaccine seroconversion is low if given less than or equal to 12 months of age. First dose seroconversion according to Nelson 87% at 9 months, 95% at 12 months and 98% at 15 months. So it is recommended to give measles vaccine after 12 months rather than before 12 months. If child had received vaccine less than or equal to 12 months, then 2 doses of vaccine need to be given after 12 months of age. Autism and encephalopathy are not linked to measles vaccine. You need to remember. Already previously MCQ has been asked on this topic 2 to 3 times. Whether the vaccines are linked to cause autism or not. So here is a vaccination schedule. Here is a vaccination schedule in India. So we give MR first at 9 to 12 months, again MR2 at 16 to 24 months. But the Nelson says the 2 doses should be given after 12 months of age because seroconversion is less. So let's see IAP schedule. In IAP we have MMR vaccine. The first dose is given at 9 months and second dose at 15 months and third dose at 4 to 6 years of age. So this is following according to Nelson. Even though first dose is given at 9 months, but the second, third dose are given after 12 months of age. This is the American Academy of Pediatric recommendation. Vaccination schedule. We have measles, mumps, rubella. They give first dose in between 12 to 15 months and second dose 4 to 6 years. They are following the guideline from Nelson or the CDC guidelines. Post-exposure prophylaxis. Susceptible individuals exposed to measles may be protected from infection either by vaccine administration or immunoglobulin administration. The vaccine is effective in preventing or modification of the measles if given within 72 hours of exposure. Either it prevent or modify the disease. That means milder form of the disease can occur. IgG may be given up to 6 days. IgG is indicated, IV immunoglobulin is indicated for susceptible household contacts, especially infants or less than 6 months of age, pregnant women, immunocompromised ones. Thank you.